Hi everyone, my pillow today. Okay, today is the 13th of January, 2018 in New Zealand. And yesterday I talked about debunking the myth about midwives. And today I said I was going to debunk the myth about the best care provider being a obstetrician or a doctor. God, I feel like an old lady. So it was really only in the 1900s that the obstetrical profession even really existed. We sometimes think that what exists now has always existed. Yet as humans, we've existed for a very long time, and modern maternity care has existed for a tiny, tiny amount of time. Throughout history, we either gave birth on our own, we gave birth where we lived as a family, or we went away with others to give birth. Those others were people we knew within our tribal group or in our village. It was rare that there was another, and depending on which culture. So during the American Revolution, for instance, it was barbers who did surgery. And there were court physicians in European countries. And there were physicians in China, and they dealt with lots of different things. But the thing that's really important to understand is that we can look at history, we can look at statistics, but the reality is you're only interested in your birth. And as a charitable trust in New Zealand, and holding the Birthing Better skills, Birthing Better families, we're only interested in their individual birth. So as a trust, we're only interested in your individual birth, your obstetrician, your midwife. What do you do at your birth? So there's no doubt in the United States that most people go to an obstetrician. And once their baby is born, the obstetrician doesn't care for the baby. It's a pediatrician, either in the hospital on staff or you have a pediatrician who comes in. So an obstetrician is limited to your pregnancy and your birth, whereas midwives, if you have a continuity of care midwife, will often give you care in pregnancy, at the birth, and for a period of time after the birth. So there is a difference if you want continuity of care. Now, in 1990, when midwives became the lead maternity carers in New Zealand, at that point there were 3,000 GPs who were doing birth, and they offered continuity of care. They didn't say that, but they did in practice. So GPs will see you in pregnancy, be at your birth, see you after the birth, and continue to see you after the birth. So our obstetricians out to get women? Is the huge rise in caesareans something that is due to the obstetrical model? Is it due to us as women? Because when I gave birth in the 1970s, there was a 3% cesarean section, and everybody just sort of labored. If you were in labor for 72 hours and you were in a hospital, you often were in a ward or just by yourself. And you just kept going. There was no fetal monitoring. People would listen with a stethoscope every 4 hours, or a pinard, which is that wooden thing. But there was very little actually assessment or monitoring or procedures done. There were these funny things done when I gave birth to my first child, where you were given an enema or you shaved, and that wasn't because of a risk to your baby. It was because women had died of sepsis, puerperal fever, and they were trying to reduce the amount of germs down at your vagina that could go up into your uterus and cause you to have blood poisoning. We laugh at these things now. How did forceps come into being? They came into being because babies got stuck in second stage. Why did they get stuck in second stage? Well, as we discovered as Birthing Better families, it was because we had tight crotches. Now, this is where the myths are so incredibly weird. I was told to do Kegel exercises, pelvic floor exercises, tighten up, make my pelvic floor tight. that so goes against what we need to do in order to let a baby out. So if we as women are tightening up our pelvic floor because we think we need strong muscles to push our baby out, then we have a myth going into pregnancy and childbirth that can cause these problems. Sometimes we're just structurally tight in our vaginas. Men love tight vaginas, and women like having tight vaginas. And many women in South American countries started to want elective cesareans by the 1980s because they wanted to remain tight down there. So, and it was people who were socially upwardly mobile, who had come out of cultures that still had lay midwives or traditional or village midwives who suddenly got some money, and they now wanted to take advantage of the modern world, and modern medicine was part of it. So we have this sort of love-hate relationship with modern medicine that changed from barbers who did surgery to having lots of assessments, monitoring, procedures as standards of care. So is an obstetrician the best care provider? Are you safer with an obstetrician? Which means, are you safer in hospital? Well, that changes, doesn't it? Depends on your hospital. If your hospital has had a recent history of an outbreak of antibiotic-resistant bacteria, you probably are not as safe in that hospital. Or maybe you're safer because suddenly they've figured out what they need to do. If you have lots of people attending you in a strange environment, in which that environment has lots of sick people and people coming and going, and other families visiting, are you at higher risk than you are at home? On an individual basis, you have to make that decision. That's not a statistical basis, because you can look up statistics, but it's what happens to you. And that's why Birthing Better Families developed skills, so we could reduce and prevent the risks that could occur from something happening to us individually. I have seen hundreds and hundreds of birth professionals practice. I've never seen anybody, a midwife or a doctor, an obstetrician, ever intentionally hurt people. I've seen very strange things, and I don't know if I had been in charge whether I would have done the same or different. When we are confronted with challenging situations, we try to bring our best skills to those situations, and skills are taught to us. So if we've never been taught to internally go in and manipulate a baby, then we don't have that skill. If we aren't taught as obstetricians to use forceps gently or apply vacuum suctions so that they don't damage the baby, then we get clumsy because our skills aren't practiced. And if we're going to practice forceps, we have to use forceps a number of times. A number of women will have birthed with us when we are learning. And if you think that that's bizarre, think about all the pilots. You get into a plane. That first officer is learning. They've been trained to a certain point, but they have to learn. That midwife that you've hired, she's learning. Unless she's done how many births? I can remember being at a birth with a face presentation. Afterwards, we looked up 1 in 500 births or full face presentations. Wouldn't it be nice if we had 500 births first before we had a face presentation? But you know what? That would still be an unusual situation because those 500 births weren't a face presentation. So we also live in societies in which we have professional admiration. We go to a professional to do a tune-up in our car. We hire professional nannies. If you have money, you hire cooks. So gardeners. We have a professional fixation. So that means when we hand over skills to professionals, we are at the whim and the mercy of who that professional is at the day. That professional obstetrician who you are going to may have a family. His child might be sick. He may have had a fight with his spouse. She might have had a birth yesterday in which something went wrong, in which she, in self-reflection, felt that she could have done something different than she did. The professionals we see are human beings. And so it's a question of what is going to happen with the professional obstetrician that we're going to go to, and we put the health and well-being of our baby in their hands. And this is why the Birthing Better families who developed these skills in the early 1970s began to take charge of their births. Now, one of the curious comments that people make to us all the time is, if families are skilled, then they're not going to want to have a midwife or an obstetrician, right? They're going to just want to do the birth on their own. And we have always thought, what's that correlation? How did you, so that's like a 1, 2, 3, skip a few, 99, 100. Skilled families still want birth professionals because birth professionals have been at a lot of births. They've seen a lot of things. So when you're skilled, it doesn't mean that you don't want to be around a professional. It just means that you want to share in your role and tasks better. So a birth professional, an obstetrician, is a highly skilled medical professional. And in order to do a cesarean, in school, they would have had to do a number of cesareans in order to do your cesarean, which means a lot of women are having cesareans because they have to learn on women. So you are going to an obstetrician who professionally is trained to do a cesarean. A general practitioner who does births isn't trained to do a cesarean. A midwife is not trained to do a cesarean. So you are already going to somebody who can rebuild your engine rather than can do a tune-up or check your oil. And you know that. So you are more likely to have a cesarean when you go to an obstetrician who's been trained to do cesareans. That makes sense. But it doesn't mean that you have to have a cesarean, particularly if you're skilled and you've prepared your body for birth and you manage birth. Then the reasons for a cesarean come down hugely because the vast majority of cesareans that are non-medically mandated. So if you have a medical reason, you really have a medical reason, then that cesarean is good. It's good because in cultures where you don't have one, then that medical reason can cause a severe injury or death, perhaps to your baby or to yourself. But most cesareans really are not medical. Most cesareans are caused by a delay in first stage or a delay in second stage. In New Zealand now, where they've basically stopped using forceps in the delivery, they literally, if your baby hasn't delivered in a reasonable amount of time, which is 2 hours, 3 hours, 4 hours, they push the baby back in and do a cesarean. We can prevent that individually if we've learned to do the internal work for 8 weeks. But we haven't told each other as women that that's important. So we are going into birth without being skilled. So how can we prevent a delay in first stage, dilation? Well, it's simple. Those 4 types of tension that I've talked about in other live broadcasts, the conscious tension, when women tense up to pain, they don't just tense up like this, they tense up down there. The structural tension, if you've done lots of Kegel exercises, you're tight down there. That prevents the uterus from pulling open the cervix effectively. If you have structural tension, if your hips are out of balance, that can stop the cervix from dilating effectively. If you are stretching, if this large baby is coming down, applying pressure on the cervix, and it stretches the cervix, and the cervix gets to a certain point where it's very tight but can't get to that next point, that there's a delay in the dilation. We all know of people who get to 5 or 6 centimeters and get delayed. Also with the dilation of the cervix, If the baby is too far forward, if you don't have a mobile sacrum, the baby's head can pinch the cervix, and you can end up with a lip of a cervix, not fully dilated cervix. So the obstetricians are trying to then reduce these problems. They do it by augmenting your labor, and then the augmentation of the labor often goes along with pain reduction. Even people who aren't having their labor augmented, if the woman isn't coping with birth, she's offered or given pain reduction. So the two causes of non-medical cesareans are the delay in dilation or the delay in second stage, or women aren't coping with birth. And so the obstetricians are then using their skills to help resolve these problems. There's this thing called a cascade of interventions. Is that real? Well, it was only in the 1980s that the word intervention began to be used. Prior to that, people didn't refer to anything, maybe, or they just called it what it was. They had an internal done, or you had monitoring done. But when you break it down, there are assessments, there's monitoring, and then there are procedures. There's always going to be standards of care, whether it's with a midwife or whether it's with an obstetrician. If you individually are important, you have to find out from your midwife or your obstetrician or your GP, what are the assessments or monitoring or procedures that they feel comfortable with, because their professional career is on the line. So each one of them will be comfortable with doing X, Y, and Z. And if you go into the hospital, then you are dealing with the standards of care of that hospital, because that hospital doesn't want women like yourself going back and saying, you didn't do that. In the United States, no one has been sued for an unnecessary cesarean. They have all been sued for not doing one soon enough, which means that we have an expectation that they make certain that we never have a problem, which means that we have a tendency to want more medical care than may be absolutely necessary. We are risk averse, and we put that risk aversion into highly skilled obstetricians. That's why when you think of Birthing Better, and the next series that I'm going to do after I finish debunking the myths are the truths around childbirth. Because if we're going to change the conversation around childbirth, then the fact is we have to understand really the role of you, me, everybody being skilled to birth our baby. And it goes back to those roles. The obstetrician or the staff, it could be an obstetrical nurse or a nurse midwife in the hospital, they are skilled within their profession, and they have specific skills to those professions. What are the skills that you are bringing into your birth? You don't have a profession. You have a task to do, and that task is to birth your baby. If you don't know how to birth your baby, if you have not prepared your body accurately or well or effectively to let this baby come down, through, and out, then you are more likely to end up with a non-medical, unplanned cesarean, because that is what the medical profession at the present time has evolved to do, compared to letting you continue to labor and labor and labor and labor for days and hours on end in order to deliver a baby. So if we want to, let's say it this way, your choice is about your obstetrician. Find out as much as you can about your obstetrician. But if you really want to not rely on your obstetrician and share in the responsibility of your birth, you need to become skilled. Besides which, they're dying to see more skilled families. The obstetricians who have seen Birthing Better families wish every family had skills. So it's up to you. If you bring yourself as a skilled mother and a skilled coaching dad or other into the hospital with your obstetrician, who you see very infrequently during the labor and only at the birth, if you're highly skilled, your obstetrician and the staff attending you will be infinitely more relaxed, no matter your risk factors. So it is important for you to understand that your role, your task, your skills are independent of the tasks, the roles, and the skills that your obstetrician has. And what you hope to do is bring those two together so that your personal experience is empowered under the care of the birth professional that you have chosen to work with. So tomorrow I'm going to debunk another myth, not certain which one that is today. Have a great day, and please spread these videos around your social media networks. And please tell people about Birthing Better Skills. It is the only online resource that is just skills focused, that will help you or your loved ones prepare their body for birth, developed by fathers and mothers, and used in every birth. And the skills are always successful because we then skillfully birth our babies, no matter where we are, who's with us, or the circumstances around our birth. And that's good. We need to have a skilled birthing population finally. So see you tomorrow. Bye-bye.